Bismillahirrahmanirrahim. Today's learning activity is about prostatitis and benign prostatic hyperplasia. These are the references for today's learning activity. At the end of this lecture, the second year MBBS student should be able to explain the classification of prostatitis, define acute and chronic prostatitis, define abacterial prostatitis, and describe the anatomy of the prostate. He should also be able to explain the etiology of benign prostatic hyperplasia and describe morphology and clinical features of benign prostatic hyperplasia and discuss the complication of benign prostatic hyperplasia. So in the next hour we will look for the answer to this clinical problem in which a 72-year-old man present to the clinic complaining that he feels that he cannot completely empty his bladder while urinating. He states that he has been experiencing increased frequency of urination as well as nocturia, and that he has had difficulty starting and stopping the stream of urine. The prostate is a retroperitoneal organ and it encircles the neck of the bladder and urethra. There is no distinct capsule of this organ and it roughly weighs about 20 to 25 gram, while the dimensions of this prostate gland is 4:3:2 centimeters. Anatomically and biologically, this gland is divided into 4 distinct areas such as periurethral zone, transitional zone, central zone, and peripheral zone. These areas are distinct as most of the hyperplasia they arise in the transitional zone, while the peripheral zone is the site for most of the carcinomas. The transitional zone comprises about 5% of the prostatic volume, and these are 2 pear-shaped lobes that surround proximal urethra. And here 10% of the prostatic carcinoma can arise. The central zone is about 25% of the prostate volume and it surrounds the transitional zone to angle of the urethra to bladder base. 5% of the cancer can occur in the central zone, while the peripheral zone is about 70% of the prostate volume and it surrounds the central zone, and here more than 80% of the carcinoma arise. This illustration is showing various important structures that are present in this neighborhood. Just memorize this picture and also note that how these conduits carry the urine or semen. This is the gross picture of the normal prostate from a posterior view. Anterior to the rectum and posterior and superior to the prostate are present the paired seminal vesicles that produce about 70% of the secretion of the seminal fluid. The vas deferens from each testes extend to the prostate as well, and seminal vesicle are actually the site for the metastasis from nearby organs. This is the transverse section through a normal prostate which is taken out during autopsy. The central urethra at the depth of the cut is opened anteriorly, and the left, right, lateral lobe and the posterior lobes are also seen in this picture, gross picture. The consistency is uniform and this is not showing any nodularity. About 70% of the prostate is composed of peripheral zone, and this is the lateral and posterior lobe, both lateral and posterior lobe. The small anterior zone contain mostly fibromuscular stroma. This is a pelvic CT scan just to show you important relation of the prostate and the area where you will look for the prostate in a CT. The prostate lies below the bladder, and the prostatic portion of the urethra traverses the prostate gland. It lies anterior to the rectum. The prostate is composed of glands and stroma. The glands are lined by double-layered epithelium, and the basal layer is low cuboidal epithelium, while the luminal side epithelium is columnar or secretory cell epithelium. So this epithelium is undergone in many times into papillary enfolding that is marked by this black arrow. The stroma is abundant and it is fibromuscular. In the transition zone, it contains compact fascicles of smooth muscle, and in central zone the stroma is densest and least dense in the peripheral zone, while in the transitional zone this is in between. There is a little increase in the size of prostate until puberty. At puberty, under the influence of testosterone, growth and differentiation occur. The enzyme 5-alpha reductase in prostate stromal cells convert testosterone that is produced by Leydig cell of the testes into dihydrotestosterone, and this dihydrotestosterone is responsible for prostatic growth. The castration lead to the atrophy of the prostate through apoptosis. This photomicrograph is also showing normal histology of the prostate at higher magnification. The glands are lined by double-layered epithelium that have got inner columnar and outer low cuboidal epithelial cells. The intervening stroma is fibromuscular, and there is also a small pink concretion that is typical of corpora mylaceae, and it is present in benign prostatic glands of older men. These epithelial cells, do not normally have prominent nucleoli. The pathological entities that are related to this organ are ectopia, inflammation or prostatitis, calculi, benign nodular enlargement, and tumors. The benign nodular enlargement or benign prostatic hyperplasia is the most common entity among these, and it is considered a normal aging process. Today we will limit our discussion to the benign processes only. The ectopia of the prostate is a rare event, and it is described in various areas of this region, such as bladder, root of the penis, epididymis, testes, seminal vesicle, retrovesical space, submucosa of the anal canal, pericolic fat, pararectal space, cervix of the uterus, vagina, or spleen. The inflammation of the prostate is termed as prostatitis, and it can be classified as acute bacterial prostatitis, chronic bacterial prostatitis, chronic abacterial prostatitis, and granulomatous prostatitis. So the acute bacterial prostatitis is caused by the organisms that are responsible for urinary tract infection, and these are E. coli, gram-negative rods, enterococci, and staphylococci. E. coli is responsible for more than 90% of the infection of the urinary tract, so it is the frequently encountered organism in these infections. The mechanism by which these organisms get access to the prostate is through intraprostatic reflux of the urine from the posterior urethra, or usually by the urinary bladder, or they get access to the prostate through lymphohematogenous route occasionally, and they also are sequelae of the post-surgical manipulation after catheterization, cystoscopy, urethral dilation, and prostatic resection. Clinically, the patient presents with fever, chills, dysuria, and perineal pain, and on per rectal examination, the prostate is tender and boggy. The diagnosis is made through urine culture and clinical features, and biopsy for this condition is contraindicated as it will lead to sepsis. The entity responds well to antibiotics. Second type of the prostatitis is chronic bacterial prostatitis. The organism for this chronic bacterial prostatitis are same as for acute one, and additional features are presence of prostatic calculi or local prostatic duct obstruction that lead to this chronic process. Clinically, this entity may remain asymptomatic or patient present with low back pain, dysuria, burning at urethral meatus, perineal and suprapubic discomfort. There is history of recurrent UTI such as cystitis, urethritis by same organism, as there is poor antibiotic penetration of the prostate. There is the presence of constant seeding of urinary tract by the organism, and in most cases the appearance of disease is insidious, and there is no previous attack of prostatitis. The diagnosis is made by leukocytosis in expressed prostatic secretions and positive bacterial culture, and treatment is prolonged antibiotic therapy. The chronic abacterial prostatitis is the commonest form of the prostatitis that is also termed as chronic pelvic pain syndrome. No organisms have been isolated from this chronic abacterial prostatitis, but in some cases Chlamydia trachomatis, Mycoplasma or Ureaplasma urolithecum are isolated. It is basically a diagnosis of exclusion. Clinically, this is indistinguishable from the chronic bacterial prostatitis, and there is no history of recurrent UTI, and the candidate is a man more than 50 years of age. The diagnosis is made when there are more than 10 leukocytes per high power field are present and the bacterial culture is negative. No specific therapy is available for this chronic abacterial prostatitis. When there is presence of granulomatous reaction within the prostatic substance, that is termed as granulomatous prostatitis. Presence of this granuloma can be due to specific reason or due to non-specific reasons. BCG induced and fungal granulomatous prostatitis are due to specific reasons. BCG induced is the most common cause of the granulomatous prostatitis that is present in USA, and it is due to treatment of superficial bladder cancer, and this BCG is an attenuated mycobacterial strain, and it will result in the histology same as in the systemic tuberculosis, that is the presence of a caseating granuloma with giant cell that are Lange type giant cell, and there is no clinical significance of this granuloma and it requires no treatment. The fungal granulomatous prostatitis are common in immunocompromised host, and Histoplasma capsulatum is one of the fungi that is responsible frequently for this condition. The non-specific granulomatous prostatitis are relatively common, and these are secondary to secretions of secondary to reaction to secretion from ruptured prostatic duct and SNI, and some of the patients have a history of recent urinary tract infection and there is no bacteria present in the tissue. Other types of prostatitis are adenoviral prostatitis and IgG4 associated autoimmune prostatitis. The acute cases of prostatitis morphologically present as minute or disseminated abscesses. There may be presence of large confluent focal areas of necrosis. There is presence of diffuse edema, congestion and boggy separation of entire gland, but mostly these prostatitis cases are diagnosed on clinical and laboratory finding. Hence, the biopsy for this lesion is uncommonly examined. Rather, it is contraindicated in prostatitis because it leads to sepsis. Sometimes the inflammation is accompanied in tissue which is taken out for benign prostatic hyperplasia, but this inflammation should not be labeled as prostatitis, rather it should be labeled as benign prostatic hyperplasia with acute or chronic inflammation, whatever type of the inflammation is present in that sample. There are some prostatitis that are characterized by presence of eosinophils. These are non-specific granulomatous prostatitis, eosinophilic prostatitis, iatrogenic granulomas, and parasitic infestations. This is the histologic appearance of prostatic abscess. The center is clear and liquefied, and it is surrounded by extensive inflammatory cell infiltrate. On the left, there is presence of some glands of the prostate with stroma, fibromuscular stroma. This photomicrograph is revealing the histologic appearance of the chronic prostatitis. There is presence of numerous small blue dots within the stroma. These are the lymphocytes, and these are present within the stroma in between the glands. This chronic prostatitis can be bacterial or abacterial. When it is abacterial, it is also termed as chronic pelvic pain syndrome, and there is no history of the urinary tract infection if it is abacterial, and the serum prostate specific antigen is slightly elevated in chronic prostatitis. The granulomatous variety of the prostate is characterized by presence of caseous necrosis if it is tuberculous, and Lange type giant cell. There is presence of epithelioid cell accumulation, and these epithelioid cells are confined, they are limited by lymphoplasmacytic infiltrate and surrounding rim of fibroblasts. The other inflammations of this area are, one is the malakoplakia, that is the characterized by the infiltrate that is located around prostatic duct, and it has a mixed composition, but it is histologically characterized by Michaelis-Guttman body that are intracytoplasmic calcific inclusions with bullseye appearance. Then there is nodular histiocytic prostatitis that is similar to malakoplakia in morphology, but it is lacking Michaelis-Guttman bodies. Vasculitis is also associated with inflammations within the prostate, and in these conditions the inflammation is necrotizing fibrinoid or of granulomatous type, and it is characteristic of the vasculitis that is associated. Then rarely in TERP specimen hair granuloma is encountered, and this hair granuloma is basically due to hair that is implanted by an earlier perineal prostatic needle biopsy. Another entity of this area is presence of stone. So prostatic calculi are present in 7% of the prostatic biopsies that were taken out for nodular hyperplasia, and they should be distinguished from the bladder, ureter or renal pelvis origin. The main nidus for the development of these stones are corpora mylaceae, blood clots, epithelial detritus and bacteria. The main inorganic elements in these stones are phosphated salts, calcium carbonate and calcium oxalate. They are hard, very hard in consistency, so on digital rectal examination they can be misdiagnosed as carcinoma. They are radio-opaque and they are not associated with any increased risk of cancer. Benign prostatic hyperplasia, that is also termed as nodular hyperplasia and abbreviated as BPH. It is also abbreviated as BEP or benign enlargement of the prostate in various literature. It is the most common benign prostatic disease in men over the age of 50 years. This disease is, this entity is more common in Western world and USA and less common in Asia. Its prevalence in US is higher among men, while in white American men it is present in 30% of the people, and they show moderate to severe degree of benign prostatic hyperplasia. It is present in various percentage in various age groups autopsies. This entity is rare before the age of 40 years and it is present in 20% of the autopsy specimen or autopsies of the 40 years of age, while in 30% it is present 30% in 50 years of age group autopsies, and this frequency increased to 80% for the age of 90 years, but there is no correlation between histology and clinical picture. The prevalence of BPH is far greater at autopsy than it is suggested by clinically apparent prostatism. 50% of those who have got microscopic evidence of BPH have got clinically detectable BPH, and 50% of those they have got the clinical symptoms. So it is not necessary to develop symptom in each and every case. The nodular hyperplasia is not a pre-malignant lesion. The series of events that is involved in the progression of benign prostatic hyperplasia is initially the hyperplasia of stromal and epithelial cell that will lead to the formation of large discrete nodules, and these will compress the urethral canal and result in narrowing of the urethral canal, especially when these nodules are present in the periurethral region. So this will result in partial or complete obstruction. The cause of BPH is not fully established. However, a few etiological factors such as endocrinological, racial, inflammation and arteriosclerosis have been implicated in this pathogenesis, but the endocrinological basis for the hyperplasia has been fully investigated and considered as a strong possibility in its development. It has been found that both sexes elaborate androgen and estrogen, though the level of androgen is high in males and estrogen is high in females. With advancing age, there is decline in the level of the androgen and relative rise of the estrogen in males. The periurethral inner prostate, that is primarily involved in benign prostatic hypertrophy, is considered responsive to the rising level of estrogen, whereas the outer prostate, that is involved mainly in the carcinoma, the peripheral zone of the prostate, is responsive to androgen. A hypothesis is suggested that there is synergistic stimulation of the prostate tissue by both these hormones, the estrogen acting on the prostate to sensitize this tissue to the growth promoting effect of dihydroxytestosterone that is derived from the plasma testosterone. The dihydrotestosterone is the main androgen in the prostate, and the dihydrotestosterone is produced by the action of the 5-alpha reductase. There are two types of these 5-alpha reductase, type 1 and type 2. The type 2 type of this enzyme is present exclusively in the stromal cell of the prostate. It is not present in the epithelial cells of the prostate. While the type 1 of this 5-alpha reductase comes from the extra prostatic locations such as liver and skin, whereby the action of this enzyme type 1 of the 5-alpha reductase, testosterone is converted to the dihydroxytestosterone, and this dihydroxytestosterone is then reaches to the prostate tissue through the blood. So now dihydroxytestosterone is present in this microenvironment, and it is arising from two sources, the extraprostatic source and the prostatic source. This dihydroxytestosterone bind to the androgen receptor that are present in both the epithelial cell and the stromal cells of the prostate tissue, and the dihydroxytestosterone has got higher affinity for the androgen receptor and form a more stable complex than that of the testosterone. So this activity and this binding is considered more stable, and this effect is more potent than that of the testosterone. So binding of this dihydroxytestosterone, that is the stable complex, this androgen receptors then translocate to the nucleus from the cytoplasm, and after this translocation there is activation of the transcription of androgen dependent genes, and several growth factors and their receptors are produced as a result of this activation of gene. Some are fibroblast growth factor family members and transforming growth factor beta. The transforming growth factor beta, they are produced by the stromal cells, and they have got influence in this microenvironment and have got paracrine regulation of the androgen stimulated epithelial cells, and this pathway work well during embryonic phase of the life. It is postulated that this pathway is reactivated in the adult phase or late life, which lead to the growth of the prostate, result in the benign prostatic hyperplasia. The transforming growth factor beta act as an inducer of cell division, that is mitogen for the fibroblast and other mesenchymal cells, but inhibit the epithelial proliferation. Although the ultimate cause of BPH is unknown, it is believed that dihydroxytestosterone induced growth factor act by increasing of the proliferation of stromal cell, and they decrease the death of the epithelial cell. Estrogen also play important role in the pathogenesis of this benign prostatic hyperplasia, because this is relatively high in the late phases of the life. So two different forms of estrogen receptors are present: estrogen receptor alpha and estrogen receptor beta. These have opposing proliferative and anti-proliferative effect. The alpha receptor have got proliferative effect, while the beta estrogen receptors has got anti-proliferative effect on these cells. Effect of estrogen on the prostate are mediated by multiple mechanisms, and these mechanisms are apoptosis, aromatase expression, and paracrine regulation via prostaglandin E2. This illustration is describing the effect of the estrogen on the prostate tissue. Normally, there is a balance in the tissue microenvironment by regulated death and proliferation of the cell. This balance of the regulation is disturbed in the presence of estrogen, which result in the inhibitory effect on the apoptosis, and it also result in the proliferation of the cell that will lead to the benign prostatic hyperplasia. Now, as far as the morphology of this benign prostate hyperplasia is concerned, the weight of the prostate increases to up to thrice or 5 times of the normal. Normally it weighs about 20 to 25 gram. In benign prostatic hyperplasia, it goes up to 60 to 100 grams in weight. It affects the transitional zone, that is the inner aspect of the prostatic gland, and this site is less frequent site for the carcinoma. Only 5% of the tumor they arise in this area. Mostly the hyperplasia occur in this area, the transitional zone. This increase in size that is lobular in appearance, it encroaches onto the wall of the urethra and compresses it, like that is seen in this picture. It compresses the urethra, and this urethra becomes a slit-like orifice. So the nodular appearance of this prostate tissue in hyperplasia is due to hyperplastic nodule. They vary in color and consistency depending on the content of these nodules, these hyperplastic nodules. When they are mostly composed of glands, they are yellow-pink in color and soft, and they exude a milky white prostatic fluid when pressurized, while they are pale grey or firm when they are composed of fibromuscular stroma. So this illustration is describing the difference between these three conditions: the area that is involved by the nodular hyperplasia and the area that is involved by the carcinoma of the prostate. Normally, the prostatic urethra is patent, and in nodular hyperplasia of the prostate, this prostatic tissue that is nodular in appearance is compressing the urethra, and it is now transformed into a slit-like aperture. And there is formation of a surgical capsule also. We have earlier discussed that there is no capsule in the prostate. So this surgical capsule is formed due to proliferation of this cell and compression of the proliferating cell outside. It creates a plane that is helpful during surgery. Then carcinoma of the prostate, it arises on the peripheral zone, as it's evident by this picture. Now compare these two pictures. On the left, this picture is a normal prostatic cut surface that is showing a patent urethral aperture, and the prostatic tissue is homogeneous in appearance. There is no nodularity in this picture, while here this prostatic cut surface is showing lobulated appearance of the tissue, and the urethral aperture is converted into a slit-like space, slit-like aperture, and the surrounding tissue, these lobulated tissue or the nodular tissue, is forming a pseudocapsule due to compression on the surrounding tissue. So we have seen gross pictures of the prostate, many pictures of the prostate, but when received in laboratory, this is not received as we have seen in the picture. In laboratory, we receive these small chips of the prostatic tissue. These are rubbery, firm to soft prostatic tissue pieces, and these are taken out through transurethral resection of the prostate. That is a frequently performed surgery for this entity. You will come across another term, that is median lobe hypertrophy. This median lobe hypertrophy is a clinical term, and it denotes nodular enlargement that project into the floor of the urethra as a hemispheric mass directly beneath the mucosa of the urethra. So this picture is showing the whole mount microscopic view of the prostatic tissue. The nodularity is evident by this picture, and nodularity is the hallmark of the benign prostatic hyperplasia. Sometimes this nodularity is accompanied by cystic changes. In the description of the gross morphology, we have seen that there are two types of the nodules. One is purely composed of fibromuscular stroma, and that is pale gray and firm nodule. The other is the yellowish pink and soft nodule, and it is composed of mostly of glands. So the grayish firm nodule are purely composed of stromal, fibrous and muscular tissue, while the soft and yellowish pink nodule, they are composed of predominantly of glands. The individual nodule is composed of small to large to cystically dilated gland, and these glands are separated by bland spindle-shaped stromal cells. The epithelium is double-layered epithelium, the inner columnar secretory cell layer and outer layer of cuboidal to flattened basal cell, and the gland infolding may form papillary projection, so the architecture is papillary. This photomicrograph is showing histological appearance of a hyperplastic nodule at higher magnification. Both glands and stroma are involved. Here a large hyperplastic nodule with numerous crowded glands is present. There is still some stroma between these glands. The glands are larger than normal with more complex architecture. The papillary infoldings are also complex, but these glands are still lined by a double layered epithelium, that is the inner columnar and outer basal locuboidal cells. There is no atypia in these cells. This is another photomicrograph of benign prostatic hyperplasia. There is a nodule in which there is crowding of glands. The small pink concretion that is present in the glandular lumen is termed as corpora amylacea. These columnar cells are normal, and the basal epithelial cell is also normal, and the surrounding stroma is less in quantity, but the condition is benign. When the blood supply to this tissue is the prostate tissue is compromised, it will result in development of infarct. This occurs in large prostate that are affected by the nodular hyperplasia, and this gross picture is showing development of infarct, which is involving a large area of the prostatic tissue, and the size and number of the infarcts are directly related to the degree of the prostatic hyperplasia. Means if the size of the prostate tissue or hyperplastic tissue is more, it will result in development of infarct more frequently. So the true infarct should be differentiated from the necrotic changes that are associated with some of the group and some of the glands that occur normally in usually in nodular hyperplasia, and it doesn't affect the stroma, while in true infarct both the glands and stroma are affected. The mechanism of the infarct is unknown. However, the infection catheter, they will result in development of thrombosis of the intraprostatic portion of the urethral arteries that will result in the infarct. Most of the prostatic infarct are clinically silent, while some present as acute urinary retention due to edema, while some present as gross hematuria due to proximity to the urethra. On cystoscopy, there is diffuse oozing of the blood from the overlying mucosa, and there is also elevation of the serum elevation of the prostate acid phosphatase and prostate specific antigen. These levels return to normal if the infarct is removed, and if after removal these prostate specific antigen and acid phosphatase do not go down, further workup is needed. The series of events that result in onset of symptoms are urethral obstruction that will lead to hypertrophy of the bladder and distension of the bladder with retention of the urine, that is accompanied by increased size of the gland, and it is mediated through contraction of the smooth muscle, and this will lead to increased residual urine, and this increased residual urine is the common source of infection. So the benign prostatic hyperplasia, there are nodules, and these nodules are formed around the urethra. So the urethra is compressed due to these growing nodule, and there is obstruction to the flow of the urine. So there is difficulty in initiating micturition, and dribbling also result, and there is incomplete emptying of the bladder that will result in increased frequency of the micturition, distension of the bladder, and infection of the bladder, that is termed as cystitis, and this is due to increased amount of the residual urine. So this infection ascend to the kidney, resulting in pyelonephritis, that is the infection of the kidney and the renal pelvic calyceal system, and it will result in kidney damage. The distension of the bladder will also result in hydronephrosis, and it also contributes to kidney damage. So the clinical presentation of the prostatic hyperplasia are increased frequency of the urine, nocturia, difficulty in starting and stopping the stream of the urine, overflow dribbling, dysuria, increased risk of bacterial infection of the bladder and kidney, or acute urinary retention. On digital per rectal examination, the prostate is firm, enlarged, and nodular. These lower urinary tract symptoms are generally measured using a validated reproducible index that is designed to determine the severity of the disease and response to the therapy. This is designed by American Urological Association and termed as American Urological Association Symptom Index. It has been also adopted as International Prostate Symptom Score or IPSS. So there are 7 questions that are in this scorecard, and against each question the answer is graded, and then sum of these 7 question score will lead to the determination of the severity of the disease or the patient follow-up who is receiving a specific therapy. This picture is summarizing the complication of the nodular prostate hyperplasia. Here you can see that when this prostate is hyperplastic and nodular, it will obstruct the outflow of the urine, so the urinary bladder is dilated, and as it is dilated and it has to work more, there is muscular hypertrophy of the bladder, and there is increased residual urine volume within the bladder also. That is the factor that is responsible for the hydroureter and hydronephrosis, that is the dilatation of this pelvic-calyceal system of the kidney, and recurrent UTI are also one of the complications, as this stagnant urine is now predisposed to the infection, and it will result in acute cystitis, or if this infection ascends, this will result in acute pyelonephritis. So when this condition goes on without medical attention, it will lead to chronic pyelonephritis. Sometimes there is formation of stones within the bladder also. This is the gross picture showing bladder outlet obstruction. There are enlarged lateral and median lobe of the prostate gland that are obstructing the prostatic urethra. This led to bladder hypertrophy because it has to work against the obstruction with every episode of the urination. This hypertrophied area is marked by this red arrow. This hypertrophy will lead to prominent trabeculation of the bladder wall. These trabeculations are present on the mucosal surface in this picture and are easily seen. The obstruction with stasis also lead to formation of the stone. Here there is yellow-brown stone that is present and marked by yellow arrow. This is the gross picture of a urinary bladder. The mucosal surface is showing prominent trabeculation that are secondary to the benign nodular hyperplasia. This benign nodular hyperplasia predisposes this patient to infection, calculus formation, and other complications we have discussed earlier. Various laboratory studies are performed to determine the functional status and to visualize this organ and the adjoining area. The blood urea nitrogen and serum creatinine are performed to exclude renal failure, while urinalysis and urine culture are important tests to exclude urinary tract infection. Intravenous pyelogram and ultrasound are performed when blood and urine picture is normal, and these are performed usually in patients who have got hematuria and when you are suspecting hydronephrosis. The important findings, expected findings in IVP and ultrasound are elevation of the bladder base by the enlarged prostate, trabeculation, thickening and diverticulosis of the bladder wall, elevation of the ureter, poor emptying of the bladder and hydronephrosis. The uroflowmetry, cystometry and pressure flow studies are urodynamic studies, and these urodynamic evaluation are performed to determine the functional status of the bladder as well as the outflow of the urine. In the uroflowmetry, in these tests, the patient wides in the instrument and various measurements are made in uroflowmetry. The maximum urinary flow rate is recorded. If the peak flow rate is less than 10 ml per second, the patient is considered having significant outflow obstruction. The patient must wide at least 150 ml of the urine for the measurement to be considered reliable. Pressure flow studies are simultaneous recording of urinary bladder pressure and urinary flow rates, which give information about urethral resistance. Pressure flow studies identify the patient that are not going to get benefit by prostatic surgery because they provide functional information about the detrusor muscle. So they are important tests to provide information about the resistance of the urethra. So the cystourethropy is reserved in patients who have got hematuria that is unexplained after the intravenous, even after the intravenous pyelogram, and cystourethropy is also performed for transurethral resection of the prostate preoperatively. Other tests that determine the progression of the disease are validated symptom scores that we have discussed earlier, estimation of the prostate volume and the serum PSA level. The prostate-specific antigen is produced from the secretory epithelium of the prostate gland, and it is secreted into the seminal fluid where it is necessary for the liquefaction of the seminal coagulum. It is a serine protease and 32 kD glycoprotein. It is bound to the alpha-2 macroglobulin and alpha-1 antitrypsin in the blood. A very small fraction is present in free form also. The normal value of this prostate-specific antigen is 1 to 5 microgram per liter, and in cancers it is more than 10 microgram per liter. It is very specific for prostate activity. Now, to manage the mild cases of benign prostatic hyperplasia, they can be managed without medicine or intervention by decreasing fluid intake before bedtime and by moderating the intake of alcohol and caffeine containing products if the patient is taking any of these, and following time winding schedules. The medical therapy for benign prostatic hypertrophy comprises of two pharmaceutical agents. One is the alpha blocker and other one is the blocker of the enzyme that is involved in the pathogenesis, the enzyme 5-alpha reductase. So these alpha-1 blockers are alfuzosin, doxazosin, terazosin, tamsulosin and prazosin, and they decrease the prostate smooth muscle tone via inhibition of alpha-1 adrenergic receptors, while the inhibitors of 5-alpha reductase are finasteride and dutasteride. They act by physically shrinking prostate by inhibiting the synthesis of dihydrotestosterone. See, moderate and severe cases, the resection, that is transurethral resection of the prostate, is advised, and it reduces symptom and also improve flow rate, and it also decreases post-voiding residual urine. This is the first line of therapy in recurrent retention. Several other techniques have been introduced that decrease the amount of excessive prostate with decreasing the morbidity and within low costs. And these are high intensity focused ultrasound or HIFU, transurethral ultrasound guided laser induced prostatectomy, that is termed as TULIP, hyperthermia, transurethral electrovaporization, and radiofrequency ablation. Now we come back to the clinical scenario we discussed in the start of this activity. A 72-year-old man present to the clinic complaining that he feels that he cannot completely empty his bladder while urinating. He states that he has been experiencing increased frequency of urination as well as nocturia, and that he had difficulty starting and stopping the stream of the urine. The laboratory test revealed an increased total PSA with a proportionate increase in the fraction of the free PSA. So probably this is a case of benign prostatic hyperplasia. Now recall, what is the pathogenesis of benign prostatic hyperplasia? What is the morphology? We discussed both the gross morphology and the microscopic appearance of this disease or entity, and what are the various laboratory investigations that are available to see the progression of the disease, and also to see the extent of the disease, and how do you manage this benign prostate hyperplasia.